you very much. Well, welcome everyone to this plenary session. My name is Gary Smith and I'm the Chair of QIP and the Director of AgPal and the Co-Chair of the Conference Program Committee. So thank you for attending this plenary session this afternoon. It's my pleasure to facilitate this plenary session on global challenges in primary care. Today's topic is phased in a question. If developing primary care and population health management are solutions to our current challenges, then how do we ensure that they happen in practice, not just in theory? There is no one better to provide us with some insights into this session's questions other than our key speaker today. Mike Farrar has had an extensive career in the reform of the primary healthcare sector in the UK. As Chief Executive of the NHS Confederation, he is responsible for the major program of primary care reform and implementing the new NHS care commissioning system. His list of achievements are too many to mention, but there are two areas I just wish to touch on. Firstly, his commitment to his charitable sector, to the charitable sector in the UK, especially in the sporting arena, where he has and still is giving back to the sector his learnt leadership skills. And secondly, he's a cricket tragic. And I have spent hours, along with other people in this room here today, with him at the Ashes in Australia on occasions. Please welcome Mike Farrar.
Thank you, Gary. I have to acknowledge that last point. I did manage to find myself in the Gabba in a closed box with 13 Australians while England were getting absolutely hammered all the way through the game, not being able to leave. Anybody who's had that experience will know that this is a joy to be with you today. Because if it all goes badly, I can walk away this time. But anyway, thank you so much, Gary. I really appreciate it. And it is fantastic to be here. I'm really grateful to ISQua for inviting me along. And I have to say, spending time with people in the sessions has been a joy. Listening to different perspectives about some of the challenges that we face, but seeing that similarity of challenge and the desire to share knowledge and experience is very humbling. And I hope today, in sharing some of my thoughts, to give you some extra sort of like thinking and contribution to the way in which you might be able to help support your countries, your systems, your colleagues, and most importantly, your populations that you serve to have higher quality and safer care. Let me just say a little bit about me. And the reason to start here is not because I want to be modest, but I want to legitimise what I'm going to say. What I've been conscious of throughout the 2 days is the quality and the depth of research evidence that people bring to these conferences. And of course, the issue is that the rational arguments, the business case for quality and safety are so profoundly developed, really, in so many ways, that it is hard to understand how is it that we're not doing this day in, day out in a routine way. And the truth is that there is still a disconnect, in my view, between the people who understand about quality and safety and the mainstream general management or general policy making of our countries and systems. And my legitimacy as someone who has been a manager and a system leader in trying to implement change to try to bring quality and safety to the fore. And I say that because the 960 people who are here get this. But we are not the issue. The issue is those people who are not here, outside of this room, currently under pressure and stress to deliver health and care services, who really aren't in that same space, not because necessarily they don't want to be, but either they don't understand or they're not given the time and space or the incentives by the regulatory and financial operations of their system to be able to sort of deliver this. And when you think about the current challenges that we face globally, and I'll try and illustrate that, We have an excess of demand for health and care services over our ability to supply it in the way that we've always done. And that's both over and above our finances, and it's over and above our workforce. And really, if you think about that, that should be the greatest moment in time for those leaders to reach out and pull improved quality, improved safety, because we know that gets added value for every dollar, every cent, every yen, and every currency we spend could be added value if we were able to pull that. And yet, my fear is that the kind of pressure that those leaders are under is really taking them in the opposite direction. And after COVID, where the demand has grown and we have latent demand, the risk is that despite the efforts of people in this room, that pressure on resources will mean we have less safe services and poorer quality services by the end of the decade, which would be an absolute tragedy. So I think what I want to talk to you about today is, as someone who's tried to lead change in systems, is not what we should do, because I think we know that. I think the people in this room know that. But it's how are we going to get that into practice? Hence why this topic. And crucially, I want to talk about this idea of primary care and population health management. Because my hypothesis is that even in the systems that are pursuing safe care, and really pushing hard, it is the organisation of care operating at the system level. We heard Liam and Shams this morning talk about quality has got to come in at every level in our system, and not just at the clinical interface or the policy interface, but actually at the delivery and organisation of care. And it is my hypothesis that we are still fixated on our hospital or residential facilities, and we have an opportunity which we struggle to deliver on, about moving our focus into primary care and further into population health management if we are to be successful about getting high quality care. It is a dangerous place to be, in the wrong place at the wrong time with the wrong person. And so if you believe that mantra, that the right person, the right place, the right time, then my view is that that has to be an emphasis in our systems to earlier intervention, to prevention, to thinking population, not just patient. And that is a route to safer care. So that's what I want to talk about. I also want to say one thing about what I'm going to share with you by way of illustration and experience for that. I have predominantly worked in the UK, although I've had the pleasure to work in Japan prior to the Ukraine war, in the Soviet Union, in Australia, New Zealand, America, Canada, and parts of Europe. But my lived experience is the UK. So when I talk about some illustrations to, if you like, support the points I want to make, I'm really hoping that those of you who are in the audience whose systems are organised slightly differently, who may well have avoided some of the pitfalls or indeed adopted some of the solutions, that you will be able to see something of a mirror to your own systems. And ideally, at the end of my presentation, I won't just get those awkward questions. I'll actually get people who can also contribute to, this is how we've managed to do this in our country. So I'm going to use a lot of UK examples, but I'm really hoping they offer a mirror to you. So, in thinking about how, I think we've got to think, and we talked about this morning in that brilliant session with Liam and Shams. We talked about, and I think it was David from Canada who challenged us and said, it's largely rhetorical, we've got to get into the practical series of change to make things different. And so, what do we know about change management? Well, actually, the people who know about improvement science, you people in the room, the quality and safe care experts in the room, also know about change management. This is a really simple model. It's a model that I use constantly where I'm working with leaders across health and care in lots of countries. It's a really simple thing that says, if we start up here in the sort of top left hand with the fact that this is where we are now, and we want to go somewhere different, i.e. we want to move towards more population health focus, to empower primary care to do more sooner, keep people living independently, then we've got to have a vision that is a compelling narrative and a compelling story about what that future could look like. And that's part of what leaders do. But the literature around this model says that you're only likely to be between 5 and 10% successful if all you do is put your strategy out there. For organisational change at the scale we need it, we then need to go to the next level. And the next level is the mechanisms. Don Berwick, we know every system is perfectly designed to get the results it gets. What we know, when Don said that, and he was reflecting the thoughts of others, was that we've got to come one layer down and say, so why are we in the situation where we've not quite got to the point, not just about quality and safety embedded into all systems, but we've not actually moved that dial into prevention, population health management, and early intervention, early diagnosis, and management in primary care settings. And so we need to understand what's driving us, because this model says that if we expect to get something different, we're going to have to change those mechanisms. And I want to run through some of those with you. But crucially, this model also says that if you only do the top 2 tiers of this model, you're probably going to improve your ability to change things, but you're only still going to go up by 5 to 10 percentage points. And what you've really got to do, if you want to be getting up around the 40 to 50% success approach to real change, and we know how difficult change is to embed, and so that kind of level of change in all sectors, by the way, is a good success rate. But if we want to get at that, we've got to understand what is in our minds which is leading us to adopt these mechanisms that are getting these current outcomes. And fundamentally, if we want to change things, we've got to expose those mindsets, be honest with each other, challenge each other, and say we will need to adopt different mindsets that underpin those new mechanisms to get a different outcome if we expect to be successful. And like I say, this model, you can see it in the literature of change in all sectors, absolutely says that unless you're prepared to work at those 3 levels and be honest and transparent about those mindsets, and I'll share some of the ones with you, we're not going to be successful. So, if we now start to think about, well, how do we start to address some of these layers, if you like, and start to get on top of it? These are the kind of things that create a compelling and shared narrative. And I should have said, by the way, right at the outset, I'm advocating for move to primary care and population health management. I'm not anti-hospital. I am not anti-institution. They have a huge place in our system. In fact, you might have read that during the pandemic of COVID, I went in, gave up all my commercial work, and went into work pro bono at King's College Hospital in London for around 6 months as the acting deputy chief exec to help that hospital manage. So this isn't about being anti-hospital, but this is about creating a vision that they too can share. So hospitals and primary care, physicians and our public and our politicians, hopefully, sharing this vision. And so we have to make common purpose. And that common purpose starts, in my view, by understanding that we've got to believe in our heart of hearts that change is necessary. We've also then got to have some courage. I'm going to illustrate these points with a few further charts for you. We've got to have some courage to lift our heads from the operational pressures and understand that we can't be so busy being busy that we can't find a way to be less busy. We've got to lift our heads up and really look to what that could mean if we adopt a different way of working. And it's no good just having a strong rational argument. We've got to connect to the emotional drivers that really dictate change. You know, we are feeling beings who think. You know, we've got to get into a situation where we understand that our feelings and our emotions drive us. And very often, it is that is driving both the adoption of change, but also being a barrier to change unless we're prepared to work at that level. And we've got to also get into thinking longer term than we do now. Our political dimensions in many, many countries across the world have shortened and shortened and shortened. And we find ourselves living, well, I'm from the UK, so what more do I need to say about short-term politics? But the thing at the moment is that we've got to lift our sights. We've got to start thinking about change now. And whilst we need some quick wins, we can't wait for those quick wins in order then to move to the next agenda. We need to be thinking now about how we're going to change this over time. And then, of course, we've got to recognise that we don't sit in a vacuum. There are things going on all the time around us that are changing the way in which we deliver care. If we think we can carry on delivering health and care in the way we've always done and just move towards an improved measure of quality and safety, we're wrong, because the world is changing around us. And so data is changing things. access to information, we're seeing this ability for people themselves to understand their own health and their own healthcare in a very different context. And that information is an asset to us, not a problem, but I'll come on to give you an example of where I saw people saying how dreadful it was that people were walking through their surgery doors with paper cutting, saying, I've seen this technology that might help me solve my condition, and that being treated with contempt by the healthcare professional. That's what I mean about mindsets to change. And of course, the other thing is that we are in a world shortage, if you like, of our work. So we've got to think differently. And so that context, along with these kind of factors, is why we need a narrative that can really help us. So let me illustrate a couple of those points. Not rocket science, this. I love this graph because effectively those blue bars are the countries, OECD countries, they're the percentage increase in their GDP. And for every country, with the exception of Estonia over this time period, their healthcare spending was exceeding their ability to fund that through their GDP. Or they were having to make priorities and choices that potentially were at the expense of education, for example, or other spending on civil society, which again can have a knock-on in terms of health demand. And this is over a 22-year period pre-COVID. So you can see that the idea that we have the ability to carrying on, is simply not there. If we also move on to my second point, which I was trying to describe to you about our ability to lift our heads. Now, this is probably the worst bit of evidence-based data you'll see in this entire conference. But just to give you what this is, for the last, I think probably about 10 years now, I've been talking to chief execs. This is a colleague of mine, Simon Shepherd. He works around sport, and this is about how often do you reflect on your work? In other words, how often do you reflect, could I have done things better? Is there a better way out there? And before COVID, we had around 30% of people on a weekly basis trying to review their practice. Since COVID, what we've seen in that survey is 9%, 7%, 0% of our leaders in our healthcare systems in the UK effectively reflecting on how they're doing their job. The operational pressures have crowded in. And so the first thing is, how do we give our leaders that sense that they've got to lift themselves up? If change is our currency to safer and higher quality care, then it starts with our leaders believing that things are different and possible. And so one of our challenges is that we've really got to think hard about how do we get leaders in our system who can lift their heads rather than find themselves complying with the kind of challenges around them. And if we think about these workforce pressures, this is the GPs, this is a period of time going back quite a long way here. And interestingly, you can see one thing, and I'm going to use this rather immodestly as a claim to fame, because one of the points of legitimacy that I have about talking to you today, Gary was very kind in referencing my reform of primary care in the UK. But the 3 years that followed that reform were the only 3 years in NHS history, and we can go back now around 80 years, where as a percentage of the new money coming into healthcare through that period of time, there was proportionately more money given to primary care than went into secondary care. So imagine that. So we've talked a good game about we primary care led NHS, but the only time in the NHS history, and that led to the growth in workforce. Sadly, that then started to go down, and we're seeing that the primary care workforce itself is depleting in a UK context. So if we're expecting to move work and to get people into an early stage of diagnosis, that the first point of our narrative has got to be that this isn't about shifting workload to you guys. This is actually about doing the right thing by patients and empowering you with resource, with support, with smarter ways of working, with better intelligence to pinpoint the right people. Otherwise, the first point of rejection is not going to be the policy. It will be our colleagues in primary care saying, whoa, we can't absorb anything more than you're asking us to do here, even if it's the right thing to do. So these things, this is where I come on to, being able to align the mechanisms that we have about workforce planning, incentivizing people to work in the sector with our policy ideas. And therefore, it's no surprise when that's not been happening, that what we were describing before as this left shift into primary care and population health management has not been delivered in practice, going back to David's question this morning. And of course, in this narrative, we also have to have the support of the public. And I've got some really interesting stuff here from the public. The first thing is the public is not homogenous. And what COVID told us rather shamefully was that even in a country that's has been proud of its ability to offer fair and equal access to care, is that people have different experiences. And I'll show you some data in a second. And so when we're talking about getting the public on side, very often those people with the greatest amount of health need who would drive costs in our system are the people not accessing care and therefore not getting safe and high quality services. And so we've got to think very differently about how going forward we prioritise that. And I've seen some very powerful demonstrations of that in the workshops this week about, thinking about equity, that fifth aim, if you like, the quintuple aim. But actually saying it doesn't deliver it. You've got to have some processes that get at it. And one of the things that I found is really helpful is when you say, well, why don't you come into services? What is it that our services are getting wrong? And when people talk about it, trust is the single most important factor in whether people will access services. And this is research from the University of Nottingham, which I've been talking a lot about because I think this is a game changer. And it says three things. One that I think we know. If you want people to come forward and use our service, if you want fairer world, and I remember talking to a colleague who said, there is no such thing as safe care if it's not safe care for all. So forget it. And that was a really big challenge about who needs to benefit from safe care. And basically, what this says is for people to, do you look like us? It was a point raised in the discussion on the ISQua white paper the other day. When I look at you, do you look like me? Not just in terms of colour of skin or religion or gender, but do you look like me in terms of socioeconomic status? Do I believe that you're looking after me? Secondly, when I walk through your doors, do I get all the expression of those values that are on your walls telling me that everybody's treated equally? Or do I feel out of place and last in the queue? But thirdly, which is the bit that really I think it comes back to us, is are you competent at what you do? So I'll trust you, even if you don't look like me, and even if I'm not quite getting that sense that you've really got me yet, but if you do good stuff when I'm in there, I'll give you my trust. I'll support you. And I'll just ask you to consider one thing, because this will happen in almost every country represented in this room. When we start to look into how as countries we manage COVID, okay, and they say, well, what did you do? And people died in hospital of nosocomial infection, and we had people who weren't getting the protection that they needed in different sectors. When that comes out, do you think that's going to enter into a learning environment that Sir Liam mentioned this morning, or is that going to come out into a political blaming environment? Because when we start blaming, what will happen is people's trust will recede. It won't increase. And then when we're trying to get safe and effective care and more people treated earlier and do population health management rather than just healthcare delivery, we will have lost trust and gone back even further. So this is really important about this aspect of trust, because when we do get trust and when we do give good messages, that when we did with public health messages, there's some really interesting data emerging about the fact that people, even where their governments were seen to be handling COVID badly, but people were still adhering to the public health messages, wearing masks, keeping distance, being responsible citizens. And so if we can get this right, we are credible. And they will trust us if we can get it right. And when people do trust, they give. And so when you look at the volunteering, the vaccination rates in the UK were staggering. Huge pace. Why? Not because our doctors and nurses were doing everything, but our volunteer workforce was incredible in standing up that service. So this is a really important dynamic about, can we get the faith in that narrative to say we are going to start moving care to an earlier phase of intervention. We are going to be moving money disproportionately away from some of our hospitals into getting to you earlier and supporting you. They have got to trust that, because if they don't trust that, people will march against it. And what do our politicians do? They follow our public, because that's how they get elected. And so if you want to change these dynamics, we've really got to have public trust, and it would start there. And just to illustrate this, these are UK data. Don't need to dwell on these, but this is the difference in socioeconomic status and mortality that we saw through COVID. And when you come to the more granular aspects of vaccine hesitancy, this is the distribution of people who trusted us to be giving them the right information and to come forward early. And I cannot think of a more important public health measure that happens outside of a hospital setting than vaccination if we're going to have safer care and higher quality care in the future. So, let me get on to, just check my timing. What are these mechanisms? What are these mechanisms I bang on about? So here we're talking about you've got to align your narrative with actual incentives. Otherwise, you're asking people to do the right thing despite the system. And particularly in general practice across many parts of the world where they're independent contractors with small businesses needing to make a living, we've really got to think hard about how do we align the incentives and financial flows for them. And that's a really crucial point, and I'll try and illustrate that. We've also got to use data better, because when we fly blind, we get this wrong. And crucially, we have to think about, in a population health context, using that data to get the resources we do have onto those with greatest need. Many systems of primary care across the world are open access. Who accesses those services? People of higher socioeconomic status with higher health literacy. So it dominates our resources. So if we really want to get at this, those people generally tend to get higher quality, safer care anyway. But the people who we're really trying to get to in terms of maximising and optimising our resources for the future are the ones we've got to make sure we're targeting. And really interesting, and I'll say more about this, I find that a lot of the challenge that comes out of people when I talk about this comes from our leaders in secondary care, because they only have a small part of the picture. They don't believe demand management can work, and so they have a smaller part of the picture. And it's only when you put the whole picture out that people realise what's driving demand into hospital, which is driving their claim for extra resource year on year on year, is the absence of money in social care or in primary care to manage that demand well. And this is one of the problems, is that people don't have this whole picture of the truth. When you're only giving people partial pictures, they're quite rational. They don't behave badly, they're quite rational, but they don't act in the collective interest and move that kind of resource to where it would have greatest value. And we have some challenges of scale in primary care. I mentioned small practices. You know, if you want to do big capital investments around diagnostic capability, small practices is quite difficult to do that. And so we're seeing across the world the emergence of primary health networks, primary care networks in the UK. These kind of organisations at scale are needed to really open up the opportunity of this shift into primary care population health management. And setting standards is hugely important here, because we've done a lot of work in secondary care, but as I'll show you, we've done very little in primary care. And yet, if we could set standards so that we could compare in a learning way and actually get reliability around that first point of intervention, that bends the utilisation of services all the way up the line. By looking at it at secondary care, and we know we can do this, get higher reliability because people like yourselves have implemented programs of change. If we can do that in primary care, we're going to start having a major impact on the use of resources. And then, of course, technology. You know, we can't be, sort of sat there Luddites resisting the sort of technology advances that are coming on, because they're around. And in fact, our population, our patients, are already adopting them. And what we've got to be is partners in that adoption and really help understand our patients, understand the opportunity of understanding more about your own health. And of course, as I've put there, and I've heard a number of presentations about this, our voluntary and community sector, our family support systems, empower that, and you get an even better return. So let me illustrate the point about getting the flow of things right. This is what happened when the QOF was introduced in the UK, the Quality and Outcome Framework, for the first time trying to set some standards of clinical practice for general practitioners across the UK. Before that, we had a fee-for-service system, so we had no idea what we were paying for volume, not value, as Gary would always challenge. You know, we must pay for value, not volume. And what you can see there is that there was a big drop in the management of ambulatory conditions that didn't go into hospital, and even those with non-ambulatory conditions were being managed differently. But we had a tariff system at that time in the UK, and effectively that gap in capacity created by that dip, because those individuals weren't going to hospital, allowed the hospitals to effectively do more work. And that was good at the time, because we were trying to reduce waiting times for care, so we got more people through. But the way in which the money was shared out as a consequence of that went as profit on tariff into our hospitals. What didn't come back, other than a small QOF payment in the context of the United Kingdom's payments, what didn't happen is that money got reinvested in more prevention, more development of the primary care offer, more diagnostic earlier in the pathway. And so we got that wrong. We got that wrong. And this is why aligning the financial flow is so important. It's very difficult in a fee-for-service model to do population health if you don't know who your population is. And so thinking about place-based budgeting, the kind of things that we saw in Alzira, in Spain, in Canterbury, Yon Shopping, which famously for many, many years has looked at its resource in the round. Place-based budgeting allows you to get at population health in the way that if you don't have those systems, much harder. What about workforce? Well, we know that getting scale in primary care allows us to expand and to use the talent of multi-specialty people in a primary care setting. And this you can see people will, I mentioned the narrative has got to somehow support our rather hard-pressed general practitioners to think about, well, how can we do the work that we need? And of course the answer is to really think about multidisciplinary teams, larger at scale primary care, not threatening necessarily their independent contractor status, but effectively allowing them to get the benefits of scale. And you can see the time released by this study. This is on the back of the primary care home model that I think many of you would know about with Ed Wagner in Seattle. The opportunity, we know how to do this if we're prepared to do it and get these incentives in place. And this idea of creating a single version of the truth, there's a bit of a case study here, I won't go into it, but it shows that the more you expose people to the fullness of the data, the more they're able to target their resources in a rational way. And very often in my professional practice, I get called in where leaders are finding it hard collaboratively to work as a system. And the first thing that I do is say, right, well, what data have you got in front of you? What story are you looking at in terms of that system? And unless you've got a whole system of data, you'll start getting the wrong behaviours. And the wrong behaviours lead to scepticism, and that scepticism means we protect the status quo. In fact, we sometimes that leads to arguing for the wrong things. But we've also got lots now of data that is being managed at scale to really allow us to target those of greatest need. And this is not just population need about particular communities. The interpreter system I've quoted here is on a very personal basis, allowing a real-time assessment of those people at risk of hospitalisation each day, which allows the clinicians to be able to target their resources on those people, whatever socioeconomic status, who are most likely to lose their ability to live independently and end up in a hospital setting. And the outcomes from that piece of work and that process are really staggering and showing great results in terms of reducing hospitalisation and help people manage their care in a safer way. And you can see that again where countries like Israel use that kind of granularity of data to really push their vaccination program at a global leading scale of using data. But it does challenge some of our mentality about what we're for. And this, I'm not going to go through this, but this is an article I saw recently in June, and this describes all the ways in which if we just use data in a different way, we can improve so many aspects of our health and care delivery system. In the 2000s, when I was the chief executive of the North West Health System, £12.3 billion trying to reduce waiting times, which is a key issue, my secret weapon was money, because the government committed to spend more than the European average, and so I had money to throw at it. I don't have that now. I don't know who in the room does. What I do know we have now is data. And if we use that data, we can be smarter and get better value for the money we do have. And we have to do that if we want safer, high-quality care. And this was my point about standardising care. Every one of these bars is a different condition. This is in the North West Hospital in northwest of England. And you can see the improvement quarterly in compliance with evidence-based, usually about 5-6 measures that said you get a better outcome. We've got myocardial infarction, we've got heart failure, hip and knee, community-acquired pneumonia, stroke, and getting on to things like dementia, etc., in the mental health sphere. And what you can see is that by using the technology and the techniques that people in this room know well, visible management, learning improvement, helping people, we were able to compress the poorest performers on the first year, and the gap between them and the top performers at the top, we were able to show compression. And what that was able to do was to really give you benefit. New England Journal of Medicine just assessed one of those areas, community-acquired pneumonia, against the national average. The Northwest hospitals were actually saving 980 lives in an 18-month period. So talk about safe care. We can do this. We know how to do this, but we're not doing it in primary care. And as a consequence, we're seeing variability, which is driving skepticism about the value of investing earlier in the pathway and putting more resource into primary care. And the greatest challenge there is, are our generalists, our general practitioners, prepared to share their data in a learning environment to help them deliver reliable, visible management and quality improvement? And that is a challenge. And then I won't say too much about this, other than this is something that I use with lots of leaders to talk about the future of healthcare. And this looks at two dynamics. Who's providing that healthcare? Either the public sector and communities themselves or commercial providers. And do we have an emphasis on treatment, care and cure, or can we move that emphasis to health and well-being? What's really interesting, over the time I've been working with future leaders in the NHS in England, the amount of attention that is now being paid to the left of that system, where effectively shopping for health, because we're seeing disruptive technologies, but that's where the money is. A lot of the government purses are very, very empty, but the investment in new health technology and some of the things that we want to do about health and well-being, but of course there's an attitude thing for public health systems about working with profits, people who need profit, and we've got to get over ourselves, because that kind of area is very fruitful in terms of scenario 3, and by 2030 I guarantee you that we will have a blend of some really disruptive technologies helping us with this move to earlier intervention. But we're not very good in health and care in the UK, at least, at pulling that through. We're really not good at all. In this room there are people demonstrating and exhibiting downstairs. A company I know well, Tendable, you might not have had a look at them. If you want to, you should go and talk to them. I know them well. They've got ways in which they could help us deliver more care and take time away from people and bureaucracy and things like that, and higher standards and quality. But it's really hard yards for them to get into our system, and we don't pull the way that other sectors do. So everybody has to push to us, and as a consequence of that, it costs us more when they eventually get there, because they've got a higher cost of sales. And I've developed this, and I've used this with Pfizer, with Google, with Apple, and very small genomic sort of tests and things like that. And there is a way that we know to get innovation through, but we've got to change our culture. And so that diagnostic that I do with them is something else that we've really got to get at. And then, of course, so much of this conversation over the last 2 days has been about citizens and empowering citizens. But again, just saying it doesn't deliver it. What we've actually got to do is to really get into that with people. And these are some of the ways that actually we can start to energize that contribution of people to their own care. You know, looking at carer training. And there was a great session that I did with people on Monday, not me personally, but we talked about knowledge, skill and confidence, and of course, skilling people. I'll just give you one story. My mother and father were married for 65 years. And for their married life, they only had one night apart until the last 2 months when my mother went into a care home with vascular dementia. My father was desperately sad that he couldn't look after my mum for that period of time. Desperately sad, just at the end. And all we could have done by giving him skilled training to manage her at that end point, to understand what was going to happen, would have kept her at home where he wanted her to be, away from the state which was having to fund the care. But for the lack of investment in that small amount of training for a carer, we were effectively incurring 2 months of costs. And so this idea of citizen engagement is absolutely the right thing to do, but we've also got to put some mechanisms underneath them that really help them. And I just wanted to I put the Brené Brown quote in there, and this really struck me. I've always thought and taught, actually, all my life, we need to walk in other people's shoes. And she said, actually, you never can, because you start from a position of privilege. And so you don't quite understand it. But what you can do is listen and believe. And if we listen and believe, rather than query and question, or not listen, or think we've listened, because we've understood what their position is, we're not going to get the benefit. So some really interesting stuff around that. And this one was my last one about the something for something deal. And this is a remarkable story. This is Wigan. Wigan is a post-industrial northern town in the UK. What they did was they said, right, as a local government, this was not a health service, as a local government, but the health service were partners, this is what we'll do, and this is what we're going to ask you to do. So we are going to deliberately structure a deal that says, if we can do this, will you do that to support us? And what you found, and this is a King's Fund evaluation, look at the improvement in life expectancy as a consequence of that. So people talk about these kind of things about having long-term benefit. But what you see there is a massive improvement in life expectancy for women and for men over that period, because people were engaged in their own care. A remarkable story. So we can do this, but we have to put the systems in place and the approach and the narrative to do it. Let me end finally by talking about mindsets. Very often, these mechanisms are known to us. We could deploy them. But what stops us? And it's the mindsets that we have that underpin why we do what we do that have to be exposed and challenged. And I've just mentioned a few, tribalism. We still have a sense that specialism trumps generalism. And so putting more money into primary care with generalist support and general nurses, etc., it's not as good, as sexy as putting the money in the top end of the specialist end and really doing something quite great. And those shouldn't be polar opposites, but so often in my career, that's been an underlying problem as a mindset. Secondly, we have become dominated and continue to be dominated, and I think this conference has, to be frank, if I'm being challenging to ISQua, with the biomedical approach around health. And of course, what we know is that social health and mental health are key drivers of physical health problems. And if we don't get the balance of investment and think holistically, we're not going to get the right answers. And I had a remarkable experience recently in Canada with the leaders there, where we started to describe what in the kind of period of life where you're in your 50s, a HELP assessment, not a health assessment, a HELP assessment about your financial planning for retirement, your residential planning around your own home, your ending socialisation, all those things could do that would have a big impact on your use of health services in your latter stage of health. So think holistically. We've got to move from being paternalistic and maternalistic. I like this approach, this idea that we have a meeting of experts. I'm an expert in me, and the person sat in front of me, the healthcare professional, is an expert in the condition that I'm presenting with. And that kind of way of doing that, we talked about people being visitors in people's journey of healthcare yesterday, but actually health professionals are particular types of visitors that can bring something special. And so we need to recognise that as well. And too many systems are dominated by bureaucratic general management change. I can say that because I'm a manager. You know, we've got to really unlock the power. The UK in particular is really poor at getting people with clinical experience into senior management, general management roles. And then this issue about discriminating on the back of need. Who's going to shout when we start saying, actually, the people with the greatest health need who don't use our services now are going to get first shout? It'll be our higher socioeconomic groups, and what will happen with them is that they'll influence politicians. And so we've really got to make this argument strongly about, in a world of limited resources where we're trying to get better value, we should be targeting those. And to be frank, if we're not prepared to do that, then let's go back to a quadruple aim. Because let's not say it and say this is all about equity, but then not be prepared to challenge the mindsets that will come when we genuinely start to put resources to those of greatest need. And then, of course, the great thing about population health management is the ability to move from being reactive to proactive. Because the more proactive we are, I would argue, the safer the care, the higher quality of the intervention, the more we keep people safe and away from some of the difficulties that we face in our systems. These are not exclusive, mutually exclusive strategies. This is a point of calibration. And as Gary says, and I do give him absolute credit because he's said this forever, and he's been around forever, is we've got to move from just thinking volume to thinking value. And that's, in a way, what QuAF did. And then finally, what is going to be the sort of key thing that might unlock that? I think it comes to ourselves as leaders, and who are we appointing into these roles? These brave kind of changes that we're advocating with a narrative, with change to mechanisms, smart thinking. We've got to have leaders who are humble, who are vulnerable, who work in partnership, you know, who support each other when it's tough and forgive each other when they make mistakes. And this kind of thing really is key to being able to adopt the others. So, I want to leave you with one final thought. There's a risk, because I've outlined a whole number of ways in which we have to change and things that we could do, building on the expertise of people in this room. There's a risk that this could be a bit of a council of despair, because there's quite a lot to do on my agenda here if we're going to be successful. So I want to end on a note of hope. And that note of hope goes back to one specific point I mentioned about understanding about social care. And it's a very personal story about my daughter. I've got 3 beautiful daughters, but one of them is 21 and should have been having a gap year before going to university. Smart girl. And she couldn't get to Nepal to do the wonderful thing in Nepal about the Everest Base Camp and all the rest of it because of COVID. And what she did was, instead of doing that and the travels that she had planned, she went to work as a domiciliary care worker in our local community. This was paid. This was dealing with 90-year-old, incontinent, doubly incontinent, old grumpy men. You know, hopefully I'm not quite there yet, but people like that. And she went to work that, and she absolutely gave herself to it. And coming out of that, she's now saying, I'd like to be a social worker. I like the idea of doing social work in a world where she might have thought, I want to be a medical practitioner. Now, I'm not against medical practitioners, but the point being that that generation of people can see the world differently. They're not perhaps as daunted or as scarred as we are about change. And really, if we can accelerate the ability of that generation to understand our problems and ask for their help, I'm very confident and hopeful that the future is bright. And I absolutely do not want to be at ISQua 2032 saying, why didn't we do this kind of shift to primary care and population health management? And my hope is that those leaders coming into our system will get the arguments, they won't have the vested interest, they'll be brave, courageous, and they'll really go at this kind of agenda, because I believe this is how we get safer and higher quality care. Thank you very much.
Yes, so when I did start in primary healthcare 36, 37 years ago, I did have hair and it was black. Thanks very much for your insightful presentation. Where you provide us with some of the hows, Mike. The challenge for us now is how do we implement the hows accordingly. We seem to have some pathways and business models in place for the acute sector, and the acute sector will still may debate whether they're effective or efficient or not. But what about primary care? Do you think we understand the business models of primary care?
No. I don't. I also don't think we know the business models of social care either, and that was one of the great revelations of COVID, was that when we tried to do holistic care, most people had no understanding of how social care was funded. The key thing that I find in health systems is that people who work in a salaried environment, usually through hospital systems or mental health trusts or community providers, do not understand that when you're an independent practitioner with your business, asking you to do something which is not commercial in your interest is difficult. Let me give you one example of who are the vaccinators in our society. They don't have to be general practitioners, because we know that nurses, pharmacists and other colleagues should do that, and a lot of our diagnostic tests could be done that way. But if the GP income depends on getting that vaccination fee, then they're always going to do it, even though we could shed their workload to somewhere else. So this is how, this lack of understanding, particularly at the highest levels of policy, sometimes is challenging. And a lot of our leaders, our senior leaders, get their careers through hospital management hierarchical training. By the time they get to the top, they don't understand partnership, they don't understand some of the variability of these business models.
Thanks, Mike. There are microphones down the front if you'd like to come forward. We have time for some questions, so please come forward and put them to Mike if you wish. Mike, we've heard a lot during this conference of the importance of primary care as being an integral part of health system reform, especially in the integrated care space. Where's the role of advocacy in this, do you think?
So when you talk, what advocacy for patients or advocacy for...
Advocacy for getting the word out to the other people who aren't here today.
Oh, right.
The hows.
Okay. Yeah, so can it be really challenging to you? And I really don't mean to upset anybody. But for some time, I've kind of worried that some of our community of people who are interested in improvement science and quality improvement, etc., have quite enjoyed the fact that that's a specialist interest, and they've kind of rather kept it to themselves. And actually, we have to. I know when we first had the kind of explosion that Don Berwick and Liam Donaldson were around about clinical governance, that became mainstream fairly quickly. But a lot of the quality improvement has kind of resided in a smaller community. So we've got to be generous to our colleagues and actually offer them this as support. So I think it's not just advocacy, it's actually offering our time and our research and our insights, and actually starting to give them the hope that actually by applying some of the things we can do, we can make their lives easier. So there's a great role, but we can't try and hold that in as a community of interest and say, and this is where ISQua's white paper and thinking about how you communicate that. If we just talk to ourselves, it's an echo chamber. We've got to talk to those people who don't get it.
Thanks, Mike. Sue, you do have a question.
Thanks, Gary. Mike, thank you for your talk. You put a slide up there about the CEOs, pre-COVID, post-COVID, 29% versus 9%, about reflection on how could they do their job better. Was there, in that data, was there a gender difference? Because in other professions or like surgical training, you'll have male surgical registrars and they never think about it. And female surgical registrars think too much about it to the point that it's detrimental to their training. So did you find a gender difference in management?
So Simon's data goes back a long way, and actually I think Simon's data does demonstrate a gender tendency, not a guarantee. I'm not sure that since then I've seen enough data to say that has been sustained, but I suspect you might be pointing to something that could do to look into.
Thank you.
Well, thank you. What you say is music to my ears. I come from Jönköping, which you mentioned.
So
we struggle with many of these things too. And I think one of the main problems is the educational system, which you didn't really mention, because that is very focused on hospital care very often. And how do you think around that to actually change that? Because you have teachers who were taught to be in the hospitals and so forth, because that's what really sets young people's minds. Because I think you're optimistic thinking around social care, so it's true, but then the educational system has to play along with that so we get it right in the end.
Yeah, it's a really good question. And I think the education system for health professionals, I think, lags behind the kind of ideas that we've talked about today. So there's a huge risk that those people who come into that with ideas about how life could change find themselves getting slightly corralled into a curriculum which they have to pass to be successful that denies them that ability to keep that kind of broad sort of understanding and have that bravery to change that. So I think we have to look as part of this, and I didn't quote it as a mechanism, but I'm really pleased you said it, because I could add it to the list now that says, and we need to change education of health professionals to reflect a new way of working. The other point is early years of life, and our local authorities with responsibility for education and those early years of life are really fighting hard at the moment to get the resource to put into those first 5 years, which we know if you get that right, you use less resources later on. And that resource is now getting directed into the backlog of people waiting for care. So effectively we are politically making value judgments over people immediately needing care versus the future potentially of our systems and sustainability. So that's the other area to try. And what I've tried to do is to try and get technical efficiency from our existing spend to release the cash to allow allocative efficiency and to get ahead and to do something about early years of life. But that is a huge challenge for us. Thank you.
One last question.
Thank you for that excellent talk. Actually, I was asking a question in the first session regarding the change management. Now, the usual issue in the quality implementation programs is that there is a defense from the doctors and other staff. You know, there is a lot of documentation, there is a lot of administrative work, and how do you defend that?
I'm just going to speak from lived experience. I find doctors hugely interesting to work with. I've done a lot of work, both managing to create the first thing is management have to understand they create the context in which great care can be delivered by empowered clinicians and not think they're there to manage doctors, which some of my colleagues sadly over the years have shown. But I think doctors like to have two things: the ability to almost cathartically share their current problems or their view of concern. If you deny them the ability to describe in their own terms what they sense and what they feel, very often you lose that connection with them. But if you can facilitate that, I think a lot of the clinicians that I've worked, because they're scientifically trained, look for the evidence, and they'll go with the evidence, and if you can provide the evidence, they find it harder, and I'm generalizing massively, and do forgive me, but trying to get people to take some of the leaps of faith and to go with emotion rather than rational argument is a great challenge with some of our clinicians, and they become resistant, and they say, I need the evidence. Give me the evidence before I'll change practice. But sometimes that if it's a randomized control trial with a big pharma company, you're talking 3, 4, 5 years, and we haven't got that time to wait. So I think we've got to try and help our clinical colleagues understand that, changing our system, not necessarily, changing the detail of clinical practice and putting them at risk, but changing the system and the environment is facilitative of them being great at what they do, and then allow them to understand that sometimes emotion is going to drive change, and we haven't got time for all that rationalisation. But we have to learn, promise them then that we're going to learn by doing, and we're going to evaluate as we go. But we sometimes, I do find the British Medical Association, who I worked opposite and with for many years, were always wanting slightly more time than I always felt we needed to get really sensible change into practice. So it's a great question, and I'm still working on it.
Thank you.
Thank you.
Well, Mike, once again, thank you very, very much for your insights and providing us your thoughts on around how primary care may fit into, and the hows and the solutions you provide to us. And thank you very much for your providing us through your words of wisdom and the work that you have done over the years in relation to primary care. And I'm looking forward to when Australia beats the UK in the next Ashes. So please thanks, Mike. Thanks, Mike. Before we finish up this session, I just wish to remind you that if you're attending the networking reception tonight at Howard Smith Wharf, the buses will be leaving at 6:30 outside the convention centre here, and I've been told they'll actually bring you back as well. So 6:30 out the front here if you're going to the reception, and they will be returning. So thank you very, very much.